Hello and welcome to our podcast Pager. I'm George Milner.
And I'm Stan Dale.
Tune in to hear us talk with some amazing people about the subjects changing medicine today. In 2018, there were nearly 38 million people in the world living with HIV. In this episode, we're joined by Andrew Lever, a professor of infectious disease in Cambridge, to discuss modern-day treatment and prevention of HIV infection. We start with a quick introduction to the virus and move on to talking about the potential for HIV vaccines, improved antiretroviral therapy, and recent advances in pre-exposure prophylaxis to prevent HIV infection following exposure to the virus. As well as new therapies, we also look at how existing interventions could be improved in the future. Professor Lever, welcome. Thanks for joining me today.
Pleasure.
So, could I start off by asking, what exactly is the HIV virus, just to set us up on an introduction?
So HIV is a virus which belongs to what's called the retrovirus family. Viruses, as you know, can only replicate if they have a living host cell to live in. Retroviruses were named because although their genetic material inside the virus particle is made of RNA, they do what's called reverse transcription. They convert that to a DNA molecule when they infect their cells, and that DNA then gets integrated into the chromosome of the cell where effectively it acts as a cellular gene. So they reverse the normal flow of genetic information, DNA to RNA to protein, by going from RNA to DNA, and hence they were called retroviruses.
And we hear about kind of two different things, HIV infection and then AIDS. So what exactly causes AIDS in this case, advanced immunodeficiency syndrome?
So HIV infects cells of the lymphoid system, particularly lymphocytes which have got the CD4 protein on. These are sometimes called helper lymphocytes. And also cells of the monocyte macrophage system, and it can integrate into either of these types. What happens after infection is that either the immune system sees that the cell is infected and tries to destroy it by recognizing the antigens that the virus is producing, or the virus itself can cause what's called cytopathic killing and destroy the cell it lives in, and that's probably the more common of the two. So over the course of a long period of time, the virus gradually whittles away at the immune system and destroys the cells which protect you and I against other infections and some virus-mediated cancers. And eventually, when the immune system has been depleted far enough, we become prone to getting infections which we would normally be able to deal with perfectly well, so-called opportunistic infections. And it's these opportunistic infections, which we now no longer have defense against, which ultimately cause what's known as AIDS, the acquired immune deficiency syndrome. And it's that leads to the death of the individual who's infected.
And what sort of infections are we talking about here then?
So they're rather specific in that the virus infects lymphocytes and also macrophages. And you can divide up the infections we get very broadly into those which our immune system concentrates on antibodies to protect us by, and those which our immune system concentrates on lymphocytes to protect us by. And the sorts of things which lymphocytes, particularly the helper lymphocytes and the cytotoxic lymphocytes, protect us against are other viruses and also fungal infections. And as the immune system becomes more and more depleted, then the range of things which we're no longer able to cope with will expand, and so there are an increase in bacterial infections as well.
And once somebody is infected with HIV, what sort of timeline are we looking at from initial infection to presentation with this immunosuppression and opportunistic infection, for example? So
the natural history of HIV is that soon after infection, the individual might suffer with what's known as a sort of glandular fever syndrome, and then they tend to be well after that. And then it rather depends on what their basic immunity is. So if they're very young, for example, newborns, then they haven't got much of an immune system to be depleted, and so they can progress quite rapidly to an immunodeficiency and opportunistic infections. In an adult with a normal immune system, it's very variable again, but on average perhaps 10 to 12 years between infection and the development of the immunodeficiency, which we describe as AIDS.
And what sort of variability is seen then in adults?
Again, it depends on what their baseline immunity status is. If they're on drugs which also suppress their immune system, or if they've got other conditions which can affect their ability to fight infections.
So anti-cancer drugs, for example.
Exactly, that sort of thing can influence the rate of progression quite dramatically. But there's also a genetic element here, in that some people seem to develop AIDS very much more rapidly than others, and there are some people whose immune system seems to be really rather potent at suppressing the virus. And at the extreme end, there are these people called elite controllers who seem to be able to be infected and not develop immunodeficiency or AIDS for 15, 20 or more years. And they're a subject of major interest as to what's the best sort of immune response to try and control the virus, which is obviously being worked on in great detail.
And has this been studied past 15 or 20 years? Because it was only in the 1980s that this virus was really properly characterised. Could it be that people could survive for maybe 30 years without even any trace of this infection in terms of symptoms?
It's possible. It looks as though elite control is finite, and that eventually people will succumb because the virus does gradually eat away at the immune system. And of course, it's a very variable virus. It mutates very rapidly. And so an immune system which is very effective at suppressing it at the beginning of an infection may become less effective as the virus mutates and starts to evade the immune response. So it looks as though eventually everybody will develop some degree of immunodeficiency, and probably, given time, everybody will develop AIDS.
And it seems like there could be quite a broad spectrum of symptoms and possible infections here. So how do you actually go about diagnosing HIV infection, which we would kind of associate with being quite a binary thing?
Yes, so the best time to diagnose it is as early as possible, because these days we start treatment really very early indeed. And often people who present with a glandular fever-like illness or just generally feeling unwell and have had at-risk behaviour which may have exposed them to HIV would get an HIV test, and that measures both the presence of the virus in the blood and also an antibody response against it, and it's the presence of both of these which confirm that the person is infected. We do sadly, of course, see people who've been infected for a long time, and they tend to present with one of these odd opportunistic infections, or particularly if they come from an area where tuberculosis is common. TB is a very common presenting infection for people with HIV, particularly from the developing world.
And I guess moving on slightly, right now, if we take the UK, for example, what are the main routes of transmission of the HIV virus? You mentioned at-risk behaviours.
So it's the same at-risk behaviours all worldwide. The major routes of transmission are by sexual contact, either homosexual or heterosexual contact, but also through blood contamination, and in particular through sharing needles by intravenous drug users. There used to be a proportion of individuals who were infected vertically, mother-to-child transmission, through breast milk, or possibly at the time of birth through the blood that contaminates all childbirth episodes. But in more recent years, we've been able to virtually prevent this by giving mothers treatment towards the time of birth and post-birth to prevent the breast milk being infectious, and also treating the baby prophylactically.
And I think I'm right in saying that HIV can't actually cross the placenta.
As far as we're aware, it doesn't cross the placenta.
So obviously HIV is of huge public health burden around the world, and in the UK, I think one estimate recently said there are over 100,000 people living with HIV. So how can we reduce, from a public health perspective, how can we reduce exposure to HIV before we even consider treating or curing its infection?
Well, there are a lot of very straightforward things, which is avoiding at-risk behaviour, using barrier methods of contraception like condoms, avoiding multiple partners, avoiding risky behaviours. These are all very well-known and well-recognised public health measures. So the fundamental issue is education, and I think this is not just in this country, it's worldwide. Much of the HIV transmission occurs because people are not aware that they are at risk, and particularly in areas where educational resources are relatively poor. So education is the key, and then very practical manoeuvres, as I suggested, to try and prevent the risk of transmission under particular circumstances. Obviously things like blood transfusion, screening, and preventative drugs to stop people becoming infectious or becoming infected are very effective these days as well.
We'll move on to those slightly later, but it's an interesting point of education for actually people who might be at risk of HIV. A recent study came out that said that if an effective HIV vaccine were to come out and it was entirely safe, only around 70% of people would actually take it, because lots of people think that they've got a zero risk of contracting HIV. Is this true?
So I'm afraid it probably is, and that's largely due to people not fully understanding what the risks are, where the virus comes from, and what it is. And that's certainly true in the Western world. But as a very small vignette, when I worked in South Africa starting people on an anti-HIV treatment, it was striking the fact that until they'd actually caught HIV, the people I was talking with didn't even know what HIV was. So the educational need is actually very, very large indeed in certain areas, and it's not surprising that transmission is still happening in these areas.
And do you think that stigma surrounding HIV infection, certainly there are many groups who are at higher risk of HIV infection, have typically been kind of marginalised in society, people engaging in homosexual behaviour, intravenous drug users, for example?
Yes, when HIV first appeared, it received the same level of stigmatisation as actually almost all new infections that appear and affect humans. And certainly in the Western world, homosexuality and promiscuity were thought to be characteristics of the people who acquired it, and that was associated with the stigma. In the Western world, I think this is less of a problem, particularly in people who understand things more. In other countries, I think it is still a huge problem. And again, this goes along very closely with countries where the educational resources are poor. So parts of Africa in particular, and areas in the developing world where they don't have the educational resources to inform people what's going on, then there's a feeling that HIV is not just an infection which you can treat, but it's some sort of curse or some sort of punishment for your own behaviour.
We've seen this going up in government as well, from some actually quite kind of shocking reports of government saying that antiretroviral treatment is essentially something sent by the West to undermine nations.
Yes, there are lots and lots of myths. One could write a whole book about the number of myths that were kicked off with HIV, such as that it was invented by the CIA to try and kill off the gay population. And antiretroviral drugs were all part of that because they were so poisonous, partly due to the fact that the early antiretroviral drugs had such bad side effects.
And we'll move on to antiretroviral drugs a little bit later on. But first of all, I'd just like to chat a bit about some actually relatively recent advances in what's called pre-exposure prophylaxis. So I was wondering if you could tell me a bit about this.
So pre-exposure prophylaxis is slightly revolutionary, but I suppose it's no different from any sort of preventative medicine. But people who, by their lifestyle and behaviour, are likely to end up in at-risk situations now have the option of taking pre-exposure prophylaxis, which is taking, in the most common form, a single tablet once a day, which contains 2 different drugs. And that has got a very high chance of preventing them acquiring HIV if they indulge in at-risk behaviour with someone who's HIV positive.
And how effective, you said quite a high chance of preventing it, how effective are these drugs?
So the figures suggest that if you take your PrEP every day, 7 days a week, it's 99% effective in preventing you getting HIV or catching HIV from another individual. That goes down the less often you take it, so that if you're taking your PrEP twice a week, it's down at an efficiency of about 70% a week.
And is this dependent at all on the exposure to the amount of virus, or just how regularly you are taking the treatment?
I don't think there's data on the infectivity of the source, and it'd be quite difficult to get that, of course. So these are overall figures as to what your risks are of getting infected if you take your PrEP, and one assumes that people who are taking PrEP are probably putting themselves at risk a reasonably large number of times per week to motivate them to actually take it.
And do you think that enough people are actually taking these drugs Because there have been quite a few questions around cost, for example, and there's been a bit of a backlash despite cost-benefit analysis adding up in favour of it.
Cost-benefit analysis is very clearly in favour. Obviously, there are still new infections occurring, particularly in certain communities in the UK, and so not enough people are taking PrEP, because if they were, it wouldn't be happening. But there has been quite a dramatic change in the last 6 or 7 years since PrEP became very widespread, particularly in the gay male population, particularly in the southeast, where the incidence of new infections really started taking a downward turn dramatically when PrEP was introduced. So it's a great step forward, and it's very effective, but more would be better.
And I think recent data coming out suggests that it's now about 50-50 in terms of new infections in the UK between individuals infected through heterosexual behaviour and men who have sex with other men.
That's true, yes.
Which is quite different from, say, a decade ago or 2 decades ago.
It was far commoner in the MSM population at that stage, yes.
Mm-hmm. Now, there's been quite a lot of excitement as well, although perhaps not that much change on a clinical level, about the prospects of an HIV vaccine as well. So how exactly could that work?
We've been working, well, not we, but people have been working on an HIV vaccine since HIV appeared. There was a famous press conference when Robert Gallo announced that the cause of HIV had been found, and the then Health Secretary in the US said a vaccine would be produced within 2 years. This is 25 years ago now, and we haven't really got a vaccine as yet. And the vaccines that have been produced have had very limited effect and relatively short-term protective effect. So I'm afraid that the prospects are still pretty poor. There are 1 or 2 vaccine candidates which look to be rather innovative and may have some promise, but it will be a long time before these go through enough clinical trials and are then licensed and are then widely available if they prove to be effective. So I think the hunt for the vaccine is going to be on for a number of years yet.
So what are some of the challenges associated with vaccinating against HIV?
Well, as a virus, it's one of the most diverse viruses there is. It's one of the most diverse organisms there is. Because of this stage in its life cycle where it converts its RNA to a DNA genome using this reverse transcriptase enzyme, this is a very error-prone process. And so the virus can change its nucleotide sequence by random mutation at least 100 to 1,000 times more often than our cells change their nucleotide sequence when they divide. And these errors get cemented into the sequence, so they change. So the virus that comes out of an infected cell is virtually always different from the virus that went in the first place. And this ability to mutate and change your nucleotide sequence and hence your proteins has 2 big consequences. One is it means that resistance to antiviral drugs has got a very high chance of developing because there's a selection pressure from the antiviral drugs, and that's, again, a reason why we use combination therapy. But it also means that the immune system, which is very good at finding antibodies and cytotoxic T cells to target particular protein epitopes on infectious organisms like viruses, will get set on something which works, and then the virus will mutate and evade that and start replicating again. And the combination of the fact that the virus mutates itself very rapidly and also is depleting the immune system as it replicates means that it's very difficult to get rid of. And the sheer diversity of virus that's around means that it's very difficult to generate a vaccine with a sufficient diversity of epitopes to give you protection against all the viruses you might encounter.
Perhaps we can contrast the lack of success so far with researching vaccines with huge success in treatment for people with HIV, for actually controlling the virus. So we're talking about antiretroviral treatment. Could you tell me a bit about that?
Antiretroviral treatment is a modern miracle and full marks to the pharmaceutical industry for a tremendous achievement in producing the largest number of therapeutic drugs for any disease in the shortest space of time that's ever occurred. There's around 30 antiretroviral drugs being produced in a period of something under 30 years. And now in combination, they are enormously effective in suppressing the virus once you're infected. And this new paradigm means that not only are people having their immune deficiency restored or they're not even developing immune deficiency, so they're living healthy lives, but they're also non-infectious to other people. And that's been one of the major contributors to the fact that the number of new infections is going down worldwide. We're just making people less infectious than they were.
So how can you make somebody completely non-infective whilst not eliminating the viral reserve in their body then?
That's a good question. It's all a matter of numbers. And when we put people on antiretroviral therapy, the two things that we judge are the level of virus in the blood as a parameter of how effective the drugs are at suppressing it, and also the rebound of the lymphocyte count, the climb in the lymphocyte count as the immune system is restored. So the level of virus goes down in the blood, and it goes down below a threshold of detection, and that's usually judged at something like 50 copies of virus per milliliter of blood. In actual fact, if you look, although the commercial assays may not be able to detect the virus, there probably is a very low level of virus replication still going on in everybody who's on treatment. But it just becomes a matter of statistics that your risk of getting infected becomes so low because there are so few viruses around in blood and hence in sexual secretions that it just becomes statistically unlikely you're going to get an infectious virus transmitted. It's obviously not zero, but it's very close to zero.
And assuming somebody is quite religiously taking their antiretroviral drugs each day, how effective are they?
So they can control the virus themselves very effectively, and the statistics on longevity bear that out. But it's very clear when you're dealing with people like this that effectively people are living normal lives, and they're living with HIV, and they're not living with an HIV that's causing any disease. So yeah, they're fantastically effective at suppressing the virus. And there have been extensive studies looking at what are called discordant couples, where one person is HIV positive, the other is HIV negative. And if the person who's HIV positive is on suppressive therapy, then there appears to be an effectively zero risk of them infecting the other partner.
Yeah, we shouldn't forget what a massive achievement this is from what was a disease that was almost invariably fatal a few decades ago to people living normal lives. And actually, there's some interesting work out that says your life expectancy might actually be higher if you were diagnosed with HIV in the West
yes,
compared to the rest of the population. Although
this is data from the Sheik study in Europe, so that I think that the quotable statistic is a 35-year-old man has got a life expectancy of 78 normally, but if he's diagnosed with HIV and treated successfully, his life expectancy goes up to 81. Now this is slightly fraudulent, of course, because what happens is that the person is under medical supervision and care, so all of their other conditions like their blood pressure and their diabetes and such like get looked after as well. But it does emphasise the fact that very good medical care is worthwhile, and that you can effectively negate the effects of what, as you say, is otherwise a lethal infection. It's all too easy to forget that HIV is lethal untreated, and certainly when I began treating people as a consultant, much of my work was simple palliative care because we had no treatment at all, and virtually everybody died until antiretroviral therapy came along.
Actually important to remember too that in many countries around the world it is still a fatal disease.
It certainly is.
So are there any side effects associated with these drug regimes? You're taking a drug or taking multiple drugs for essentially the rest of a patient's life.
Yeah, all drugs have side effects, and the early HIV drugs were very potent at suppressing the virus, but they had a lot of side effects, and that was part of the problem because adherence to treatment was not good because of the side effects. They'd affect the nerves and cause neuropathy, they'd affect the kidneys and cause kidney stones, they'd affect the fat distribution and give people buffalo humps and all sorts of other nasty effects. Modern drugs are surprisingly benign. They may have an effect on making people feel unwell for the first week or two of treatment, perhaps tired, but generally they're very, very well tolerated. In long-term treatment, of course, we're seeing that some of the drugs, perhaps the older ones, still do have some side effects. So some of the well-established drugs may be better not used in people who've got minor degrees of kidney damage, for example. And there's evidence that some drugs will accelerate demineralization of bones. But the modern versions of these drugs have largely been altered so they don't have even these relatively mild side effects. There are always idiosyncratic side effects. Some people react badly to a drug when everybody else doesn't, and we just don't know necessarily why that is. But in general, because of the diversity of drugs that's available, you can always find a combination that's tolerated for an individual.
And what are the worries, I think you touched on it a little bit earlier, about resistance to drugs as the HIV virus can mutate, the epitopes and the virus can change?
So the situation at the beginning of HIV therapy was when we had one drug and then two drugs and then three drugs, and people were given one drug and the virus became resistant to that, and they were swapped onto the second drug and it became resistant to that, etc. And what was happening, of course, was the virus was mutating randomly, but one of the mutants that emerged would be one that was able to replicate despite the presence of one drug. Now, if you give people combination therapy, say 2 or more likely 3 or sometimes 4 drugs at the same time, to develop resistance, the virus would have to acquire mutations in different parts of its genetic material, which simultaneously made it resistant to all of those drugs. And that, again, statistically becomes highly unlikely, and that's why combination therapy is so effective. It's not a new concept, and it's something I think the medical profession is sometimes a little bit slow to learn, because exactly the same phenomenon happens with tuberculosis. Combination therapy works, single agents the bug becomes resistant to, and there's also suggestions in other infections that combination therapy may be better. But in HIV, the proof is there, and combination therapy is enormously effective at suppressing the virus.
Does this work on quite strict use of combination therapy around the world rather than just single agents or 2 agents, where I can almost imagine a situation in which a virus mutates in one person, another virus mutates in another person, and you could get transfer of genetic material between these viruses, and suddenly you've brought together mutations that allow a virus to replicate with lots of drugs. You brought them together into one virus.
What you're alluding to is this phenomenon of recombination, where viruses can exchange genetic material, and then the progeny virus will have the characteristics of both the parental ones. And this can certainly occur. And the sort of scenario you're describing would happen in areas where people have got incompletely suppressed virus, or they're on mono or dual therapy, and the virus they've got has become resistant to 1 or 2 drugs. This is obviously suboptimal and not something we would aim at, but it is possible. And that may be one avenue by which the virus can develop resistance to more than one drug. More commonly, the scenario is that either people didn't take all of their drugs, or, as more commonly occurs in places where supply chains are not necessarily that reliable, a drug runs out, or the truck doesn't arrive, or the pharmacy runs out, or the road gets washed away. And so somebody who's on a combination of, say, 3 drugs suddenly finds the pharmacy has run out of 2 of them, and presses on just with their 1 drug, and the virus becomes resistant to that, and then they've really lost that drug. And so even when the original drug's supply is restored, they've got a partially resistant virus. And so it's logistics as much as anything, as much as adherence, which is responsible for the emergence of resistance in areas where supply chains are not good.
So I guess an important question to ask is, how long acting are these drugs? Therefore, is there any scope for missing out on a dose, for example, 1 day?
They vary. Some, like efavirenz, have got quite a long half-life. Others are shorter half-lives. But most of the commonly used drugs now are once a day, which means that they have got a long enough half-life such that if you're a little bit slow on taking it 1 day, it probably doesn't matter too much. It may be the case that if you miss out a day, it doesn't matter too much, but that's obviously not a philosophy you'd encourage. So there's no doubt taking it every day religiously is better than not taking it as dutifully as that.
And particularly considering that people could be taking these drugs for the rest of their lives, is there any potential for longer lasting release mechanisms?
Yeah, so that's an area of intensive research at the moment, both for the treatment and also for the preventative PrEP-like approach. People would obviously like the idea of having a once a week or a once a month injection or once a year injection of a long-acting slow release of a drug rather than having to take tablets every day. And these would be applicable for people such as in the PrEP situation, but more specifically in areas where supply chains are not good, because something like a once a week or a once a month depot injection, or even something like that, would be enormously valuable. And so there are inroads being made into these long-acting preparations, which you hope will bear fruit and provide much better care for people where it's more difficult to access HIV care.
And we've seen the same thing in, say, female contraceptive implants as well, which have been quite successful.
Absolutely, yes.
I think there's a stat here that 90% would consider switching to injections every 1 to 3 months if they became available. Because obviously it's quite a big burden to take medication every day quite religiously.
I think the statistics on taking drugs for any condition every day are not very impressive. As a race, we're not very good at adhering to everyday medication. In fact, the statistics for HIV medications are better than for most, but I guess that may reflect the seriousness of the problem if you don't take them. But I could quite understand that a once a month or a once every 3 month injection would be an extremely attractive option.
Perhaps going back to vaccines as well, there's been a suggestion that perhaps a therapeutic vaccine could maybe achieve a similar degree of suppression that antiretroviral drugs could achieve. Not actually eliminating the HIV virus, but controlling it. What potential is there here?
So therapeutic vaccines have been disappointing. There have been at least half a dozen studies to give people therapeutic vaccines and then discontinue their therapy and see whether or not that boost to the immune system has had any effect in suppressing the virus better than without it. And really none of them have shown anything more than a relatively short prolongation of suppression. So as yet, therapeutic vaccines are not proving their worth in this particular condition.
There's also been quite a lot of interest in new antibody treatment for HIV as well. Could you tell me a bit about that?
Yes, so there's a lot of interest in what are called broadly neutralizing antibodies. Just to put it in context, in somebody who's infected with HIV, an antibody response is made, and that's one of the ways that we can detect the virus is there, by detecting the fact that the host has made a response to them. But because of the rate at which the virus mutates, the antibodies which are produced are often not effective against the mutational variants that arise rather quickly. And what happens is that the antibodies which an individual has tend to be relatively ineffective at neutralizing their own virus because the virus is mutated away. In some individuals, it seems that after a very, very long period of infection, they start getting better at making antibodies. The antibodies themselves, as you probably know, can get to be higher and higher affinity as the immune system gets better and better at producing them. And in a small number of individuals, they've been able to produce what are called broadly neutralizing antibodies, which target particular parts of the envelope protein on the outside of the virus and seem to be able to neutralize a very wide range of strains of virus. And that's encouraged speculation that these broadly neutralizing antibodies might be something which could either be the basis of what we'd like to produce with a vaccine, or themselves could be used therapeutically. Now, the difficulty with trying to make broadly neutralizing antibodies with a vaccine is that it seems to take repeated years and years of exposure to viral proteins to get the antibodies to change and mutate until they become broadly neutralizing. And so it's not very logistically practicable to vaccinate people that many times to produce these. However, if you take cells out of somebody who's making broadly neutralizing antibodies, with modern cell cloning techniques, you can now grow up these cells and produce therapeutic quantities of broadly neutralizing antibodies, which can then be made up into preparations to infuse into people. And these have produced some quite striking and almost remarkable responses in human and in animal studies. Infusions of broadly neutralizing antibodies followed by a treatment interruption, in other words, discontinuation of therapy, in some cases has shown really quite a prolonged suppression of the virus for much longer than you'd have predicted, obviously caused by this antibody treatment. And in some recent studies in a primate model of HIV, a combination of an immune stimulator, rather non-specific immune stimulator, TLR7 agonist, with a broadly neutralizing antibody, led to very prolonged suppression of the virus indeed when treatment was interrupted, 6 months or a year or so. And it's really not clear how these work because antibodies themselves shouldn't really last that long. So it may be that they're sequestering the virus and presenting it in a much better way to the immune system, so the immune system can make a better response. So this is a rather exciting and interesting new approach to treatment, and there are some studies just starting up giving combinations of broadly neutralizing antibodies to humans to see whether or not we can produce prolonged suppression of the virus in the absence of antiretroviral drugs, as this may be one of these possible intermittent treatments which we were talking about earlier.
Thank you for listening to the Pager podcast. If you've enjoyed it, then head to Spotify or iTunes to hear more.
As ever, we'd love to hear what you think. Do leave us a review on Apple Podcasts, and you can also reach us via our website and our social media pages.